Hello guys, today my name is Russaal Singh Mann and today we are going to learn about jaundice. Jaundice is an increase in bilirubin levels in our blood which can cause various defects, for example a yellowing of the eye, sclera, because the collagen in sclera is very affinitive to the bilirubin present in blood, and it can cause yellowing of skin. Now jaundice mean when bilirubin increases more than 0.2 to 1.2 milligram per deciliter. This is the normal value. If it increases more than that, it causes jaundice. Now what are the components? We have to first understand what are the components of bile. It consists of bilirubin, bile acids or salts, and cholesterol. Let's talk about cholestasis. It means impaired bile outflow. In this condition, all content of bile enters into blood. Now, how is bilirubin formed? We have to understand this. For understanding this, we should know that RBCs, after completing their life cycle of 120 days, they go to spleen where they are destroyed by macrophages. This is called extravascular hemolysis because it is not taking place inside the blood vessels. It is taking place in an organ, for example, spleen. Now, to know how bilirubin is formed, first we have to know about the contents of hemoglobin and about the contents of RBC. First, there is a structure called pyrrole ring. 4 pyrrole rings combine to form a protoporphyrin. When an iron molecule is combined with protoporphyrin, it forms heme. And when a globin chain is attached to the heme molecule, it forms hemoglobin. Now let's talk about breakdown of RBC. In RBCs, there are 3 components present. One is your hemoglobin, one is your protein, and one is your membrane. Let's talk about first membrane. Membrane has to contain protein and lipids. When they break down, lipids turn into free fatty acids and your protein turn down into amino acids. And the protein present in your cell cytoplasm is also turned into amino acids. Your hemoglobin molecule is destroyed. How is destroyed? It has a globin chain which turns into amino acid. Now let's talk about the heme part. Heme part is destroyed or digested with the help of enzyme heme oxygenase, which converts it into biliverdin and iron, Fe+2 part of iron. Now the biliverdin is converted into bilirubin by the enzyme biliverdin reductase. Iron combines with a protein called apoferritin, and it forms a group of iron and apoferritin molecule combined to form a hemosiderin, which is a storage form of your iron in the tissues, iron in the body. Now, why is this combination of iron with apoferritin very important? This is because iron is highly toxic for cell, hence is combined with apoferritin. It can cause cell lysis, cell damage. That's why we don't want iron to roam freely in the body. Now let's understand some various terms. For example, the first one is hemosiderosis. What is hemosiderosis? When hemosiderin becomes more than normal but has not started to damage the tissue, that is mainly the important organs of our body, for example liver, heart, spleen and pituitary, it is called hemosiderosis. What is hemochromatosis? When hemosiderin level becomes more than normal and it causes tissue damage and damage to the body, this is called hemochromatosis. Another very important term is connectivus. In children, when unconjugated bilirubin, we'll talk about what is conjugated bilirubin few seconds later, but when just understand this. When unconjugated bilirubin binds to a structure of CNS, that is basal ganglia, and causes damage and mental retardation, it is known as connectivus. Now what we can do is, for treating the patient, so that if their bilirubin level is very increased, we can give them 10 protoporphyrin. It is a synthetic metallic protoporphyrin which is a potent competitive inhibitor of heme oxygenase, because of which rate of production of unconjugated bilirubin is decreased. So if a person is producing a lot of bilirubin in the body, we can give him 10 protoporphyrin. Now a very important thing you should know about is a drug is sulfonamides. Now why do we give sulfonamides? We give sulfonamides because if there is a bacterial infection, for example meningitis, it kills the bacteria. But you should remember, it's a very important clinical point, that you should not give sulfonamides to children. Why? Because these are displacers of unconjugated bilirubin from plasma protein. Unconjugated bilirubin binds to plasma protein, and so that it does not react with your normal cells or plasma cells and remains in a bound form. But if you give sulfonamides, it causes its dissociation, and in a child, if a child is having meningitis and you give him this sulfonamides, it will cause very important clinical complication of jaundice. That is called neonatal jaundice. So it can increase the effects of jaundice. So we don't want that. So you should remember not to give sulfonamides. Another drug is which that is called leftomycin, decreases the uptake of unconjugated bilirubin by the liver. So bilirubin is not absorbed by the liver, so it increases in the body. Now, if a patient comes with high conjugated bilirubin with no urobilinogen, then it means he has obstructive jaundice or cholestasis. We'll discuss about this, but for now, just learn this point that if a patient has high conjugated bilirubin with no urobilinogen, then it means he has obstructive jaundice and cholestasis. This is the pathway for formation of urobilinogen and how it is excreted by the body. In your consider this is your spleen. In your spleen, bilirubin is being formed. From there, it is transported into blood and it binds to bilirubin binding protein. So this complex then goes to the liver. It is uptaken by the liver, where unconjugated bilirubin is converted into conjugated bilirubin by the enzyme gluconic transferase. This conjugated bilirubin is more water soluble and can be excreted by the body from the urine also. But when I was talking about this unconjugated bilirubin, it could not be excreted by your kidneys. So now conjugation has occurred, it has become more water soluble. From the liver cells, it is transported into your biliary apparatus. From where it is stored in the gallbladder, where it is concentrated. Then it is secreted in your duodenum through ampulla of Vater. From there, it goes into your small intestine, and by the bacteria present in your small intestine, it is converted into a compound called urobilinogen. From the ileum part of small intestine, it is absorbed by the portal blood, and this urobilinogen goes to the liver. Some part of it is again excreted into extrahepatic biliary apparatus. Some part of it goes into the blood, and then it enters the kidneys, where it is excreted in the urine. So urobilinogen can be excreted in the urine. You have to remember this point. Now, the urobilinogen, which was not uptaken by the portal blood, is converted by bacteria into stericobillinogen. Stericobillinogen gives the color to your feces. It darkens your feces. So absence of stericobillinogen in your feces leads to pale stools. Now we have to discuss about the facts which cause hyperbilirubinemia. It could be prehepatic, posthepatic, and it could be because of unconjugated bilirubin or conjugated bilirubin. Let's first highlight the points which causes increase in unconjugated bilirubin. The first is excess production of bilirubin. It may be because of excessive hemolysis. Then second is decreased uptake of bilirubin by the liver. For example, I told you about the drug leftomycin. It decreases the uptake of unconjugated bilirubin and increases its concentration in the blood. Or the third point is there could be decreased conjugation. For example, there is some hepatocellular injury, so because of which there is decreased conjugation of unconjugated bilirubin. Now there can be several reasons for increase in conjugated bilirubin. First one is failed transfer of bilirubin from hepatocyte. Second is intrahepatic cholestasis, and third is extrahepatic cholestasis. Now we are talking about a first point that was causes of excessive hemolysis, which increases the amount of unconjugated bilirubin in blood. This could be because of hemolytic anemia, absorption of large hematoma, excessive intramedullary hemolysis, that is more than 10 to 20%. This can be physiologically, for example, in children, newborn children, where their alpha and gamma hemoglobin are destroyed, because fetal hemoglobin instead of having a beta globin chain, it has a gamma globin chain. The second is malaria, sickle cell anemia, spherocytosis, where the cells are spherical and they have increased fragility. And the last one is thalassemia. Others include autoimmune diseases.